So my clinical pattern was avascular necrosis of the hip. Some macro traumas that could cause this disease would be fracture of the femoral head or hip dislocation. Some other etiological causes could be corticosteroid abuse or use and alcohol abuse. So the tissues or other tissues that are involved with this disease would be the medial and lateral circumflex arteries, because as we remember, they are the arteries that will provide blood flow to the femoral head. And just as an overview on this disease itself, it's basically when the hip joint is not getting enough blood flow, that will lead to osteocyte death in the hip joint, which osteocyte death will be bone death, and then you'll have this. So some common signs and symptoms would be hip pain radiating to the groin and the thigh. Some things that they're not going to be able to do from an activity limitation perspective is anything that really has prolonged ambulation or prolonged weight bearing. So this also will include the PRs, so like walking, like grocery shopping, hiking. Again, if you have a job where you're standing up and moving around all day, that would be a potential activity limitation as well. Sports, like contact sports, are contraindicated. Some contributing factors would be the alcohol and corticosteroid frequency and use. If we get to the exam side of this disease, some precautions and contraindications would be first hip mobilizations. It's a precaution depending on the stage and the stability of this disease. Excessive shearing or compressive forces on the hip joint are contraindicated, and you don't want to overload the hip joint because you could run the risk of causing femoral head collapse, which is definitely a no-no. Posture, you could see them like when they're in the clinic, you can see them having an antalgic gait sometimes just because of the pain from this disease. When you look at common things for active and passive range of motion, due to structural changes and due to pain, you would see a lot of the times that these patients would not have the adequate range of motion, either actively or passively. And same thing with strength, but if you're doing resisted testing, you have this diagnosis, you have to understand that a lot of the decreased strength will be from pain as well. And some special tests that would be positive would be any of the intra-articular tests like the Fadir or the Scour. And obviously, like if you're palpating around the area, it's going to be tender as well. Some differential diagnosis for this disease would be like bone marrow edema syndrome, osteoarthritis, and osteoporosis. When trying to figure out the diagnostic imaging testing, MRI is by far the gold standard for diagnosing this disease. The prognosis of this disease depends on like various factors, including the stage of the disease when diagnosed, if the medial or the lateral head of the hip joint is involved. If the lateral head of the hip joint is involved, or the lateral head of the femur, it has a worse prognosis. Age, the older you are, the worse prognosis you will have when it comes to this disease. And the amount of the head that is affected, if greater than a third of the head is affected from this disease, you have a worse outlook, a worse prognosis. When it comes to referral, it's very similar to all the other diseases and pathologies we will be learning. If our patients aren't getting better after weeks of therapy, from a functionality perspective or from a pain perspective, we don't want to waste their time. So we would refer them to their MD. Some management of this disease, alcohol, corticosteroid cessation, it has a worse prognosis whenever it's being used, so to just cut it out entirely. Education up to the PTs really, or the patient, would be very important when regarding assistive devices. If the pain is too much, and again, prolonged ambulation, it will be a limitation of theirs. So maybe education about how to use, depending on the age, a walker or a cane correctly, or crutches. Hip joint mobilizations for this patient is okay if the disease has plateaued and it actually does help their signs and symptoms like their pain. For active and passive range of motion, you want to maintain the functionality of the hip, but you have to realize that a lot of times this is going to be very patient dependent, depending on how much pain and what stage of the disease they are in for this disease. If you're going to be doing any strength exercises, like you want to, or resisted exercises, I mean, you want to be training them for endurance, just because, again, their biggest limitation is being on that head consistently. So any way to be able to allow them to have prolonged weight bearing will always be a positive. Some pharmacologic interventions will be anticoagulants, stands, vasodilators, and biphosphonates, and surgical. So if none of it's working and they have to go back to the MD, one of 5 things could happen. They could have a core decompression, a bone graft, which is either a vascular bone graft or a non-vascular bone graft, an osteotomy, or a total hip replacement. And that's my clinical pattern.